Systemic Lupus Erythematosus, Part 1 of 2. Objectives. After listening to this two-part lecture, the learner should be able to recognize the various clinical manifestations of SLE, understand the diagnostic criteria, and briefly discuss potential treatments. Learners will also gain an understanding of some special clinical situations, such as neonatal lupus and drug-induced lupus. In the first lecture of this two-part series, we will briefly talk about the epidemiology, pathophysiology, and presentation, including treatment of SLE. In addition, we will begin to discuss the classification criteria, a discussion that will carry over into the second lecture. Also in the second lecture, we will talk about those special subjects mentioned above, as they often come up on USMLE exams. Epidemiology. Like most autoimmune disorders, lupus largely affects women of childbearing age. As you can see, women tend to be affected much more often than men, by as much as a 10-to-1 margin by some reports. One of the reasons lupus can be challenging to diagnose and treat is the highly variable nature of the disease. As they say, everyone's lupus is different. Some affected individuals can have very mild disease, which are manifested only by skin and joint involvement, while others tend to have serious and/or life-threatening disease. Also, lupus tends to be more common in people of certain ethnic descents, such as African or Asian populations, and the disease tends to be more aggressive in these populations as well. Finally, we know that while some people do have a genetic predisposition for SLE, there are certain environmental causes that play an important role in initiating the immune response. So in those with a genetic predisposition to SLE, what are some of the suspected triggers of lupus? Bacterial or viral infections may play a role in triggering the immune response that eventually leads to the development of SLE, although no specific pathogens have been definitively proven to date. Additionally, there is some research to support the role of certain environmental toxins as triggers of the aberrant immune response. It has been well known that DNA damage induced by ultraviolet light can lead to exacerbations of known SLE. And evidence suggests that damage may be a precipitating factor in the development of SLE in some individuals. Finally, certain medications are known to cause drug-induced lupus. However, drug-induced lupus tends to be limited and will be discussed further in the second lecture. Pathophysiology. The pathogenesis of SLE is complex. On a superficial level, the most characteristic immune abnormality in SLE is excessive formation of autoantibodies, which bind to their targets, creating immune complexes. These immune complexes can deposit in tissues such as the kidneys, where they initiate a local destructive immune response. This leads to complement activation, leading to an inflammatory response and subsequent tissue injury and damage. Other problems such as host defects in the clearance of dying cells and the presence of circulating immune complexes also contribute to the pathophysiology of SLE. Treatment. The treatment of SLE is determined by disease severity. For those with mild disease primarily limited to the joints, non-steroidal anti-inflammatory drugs are a mainstay of symptomatic therapy. Hydroxychloroquine is indicated even for individuals with mild disease and has been proven to provide many long-term benefits. Symptomatically, this drug tends to help those with skin and joint problems. Flares of lupus tend to be treated with corticosteroids, either oral or IV, depending on the severity of the disease manifestation. Patients with very active, multisystem, or life-threatening disease are often treated with immunosuppressive or disease-modifying anti-rheumatic drugs, also known as DMARDs. Only hydroxychloroquine, aspirin, glucocorticoids, and belimumab have been approved by the U.S. Food and Drug Administration to treat SLE. Azathioprine, methotrexate, and mycophenolate mofetil are used to treat manifestations of SLE, including inflammatory arthritis, severe rashes, nephritis, neuropsychiatric, and other manifestations. Cyclophosphamide chemotherapy is used to treat severe or life-threatening manifestations, most commonly lupus nephritis. Belimumab was recently approved for treatment of active autoantibody-positive SLE despite treatment with standard therapy. And now we will move on to the classification criteria. For research purposes, an individual must demonstrate 4 of the 11 criteria listed here to be classified as having SLE. Although these are not official diagnostic criteria, they are often used as such, and we will now spend some time reviewing these criteria in detail. The antinuclear antibody test, or ANA, is a highly sensitive but not specific test for SLE. What do we mean by that? Remember, sensitivity can be used to rule a condition out, so if a patient has a negative ANA, then lupus is very unlikely. However, this is not a very specific test, as there can be many other reasons an individual can have a positive ANA. For example, many other autoimmune conditions and some chronic infections are associated with ANA positivity. In addition, at least 5 to 10% of normal individuals have a positive ANA, and the incidence can increase with age. Consequently, a positive ANA alone has minimal clinical value. The ANA test is generally performed using direct immunofluorescence, which usually like the photomicrograph picture through a microscope. When ordering an ANA test, the result is usually reported with a titer as well as a pattern, such as speckled or nucleolar, which can suggest specific autoantibodies detected and may, therefore, be of some prognostic significance. The other lupus-defining autoantibodies are those to double-stranded DNA and the Smith antigen. Both autoantibodies are considered highly specific but not sensitive, meaning there are few conditions other than SLE that can cause one of these autoantibodies to be present. Additionally, detecting certain antiphospholipid antibodies in moderate to high titer fulfill the criteria as well. Although please note that not all patients with lupus have antiphospholipid antibodies, and not all patients who have antiphospholipid syndrome have lupus. Finally, while there are many different hematologic abnormalities in patients with SLE, only the following are part of the classification criteria. First, evidence of a microangiopathic hemolytic anemia, a white blood cell count less than 4,000 on 2 different occasions, and an absolute lymphocyte count less than 1,500, once again on 2 different occasions. In conclusion, lupus tends to be a disorder of young females. Furthermore, the disease is more severe in patients of certain ethnicities. The disease can affect every organ system and therefore has many varied clinical presentations. And finally, 4 of 11 classification criteria should be met to diagnose a patient with SLE.